So now we move to Martin Röösli, environmental epidemiologist interested in EMF pollution also. He is also member of ICNIRP.
Okay, thanks a lot. Amazing, the last session, and still so many people here. So I think you have chosen wisely the topic, and I'm very grateful that you have invited me to talk today about that topic. You said the present and the future. Actually, I would like to start with the past, or my past. It's really a topic that has quite some relevance for me. I think it is my main motivation to even do science, to better understand whether there are more vulnerable people, whether people react. And when I could choose in my master's studies as a very young scientist, still doing the master, about the topic to write about it, I have chosen the question whether people react to the weather. So, and I was interested in different hypotheses, like in Switzerland there's a famous wind, a valley wind, which is called the Föhn, and then people claim they have a lot of symptoms, or muscles pain, or joint pain. Obviously I was also interested in spherics and areons and all this electromagnetic stuff. And when I read all this paper, almost every paper started with a sentence, everybody is weather sensitive. If it's hot, we sweat. If it's cold, we are shivering. So as an enthusiastic student, I was really frustrated. I mean, this is so trivial. I mean, that is really not what I wanted to go for. But it somehow told me terminology matters. And I think that's also very important now for this survey. Or for this presentation. So what I would like to start is to talk a bit about vulnerability, about susceptibility, which are common concepts in environmental epidemiology, versus this hypersensitivity issue. And then also we'll talk a bit about provocation studies, diagnosis, biomarker, long-term effects, and treatment. So let's start with some other research that we have recently done, also on non-ionizing radiation, but on heat. And it's well known that if it's very hot, that the death rate is increasing, and that has been recently published by us in a paper in a study on cardiovascular diseases around the airport of Zurich. So another question in that study was also noise effects. And what you can see in the graph is if it's very hot here, if it becomes hotter, then and that's the lag, so it's on the day when it's hot, and also to some extent the day after and 2 days after, the death rates are increasing. So this is a well-known phenomenon, and this has to do with the cardiac overload, so people may have too little liquid. And if we look who has a higher risk, we could see there's some differences in terms of diagnosis, but we could also see that, for instance, females had a higher risk to die when it is high. We could see that the older people were, the higher was the risk, more or less. And for instance, the socioeconomic status played a role, or people with less education had a higher risk to die. So obviously there's different vulnerability. Not everybody will react to heat. Not everybody will die on a very hot day, luckily. So this has obviously different explanations. There might be biological higher sensitivity, or I call it here sensitivity, but what I mean is vulnerability and susceptibility. So it is usually assumed that women have more problems to cope with heat than men, so that is somehow reflected in this finding. The exposure may be different for people. Some people may live in a house which is not well isolated, so if it's hot, then they have hotter temperatures, so this may also explain some of the variability. Or some may have lower health literacy, so they don't know that they should drink more. Not white wine, but maybe water. So things like that plays a role. There could be probably other explanations. So this is very important, and also for the protection of the population, that we take into account this variability in susceptibility. But do the people know that they are susceptible to heat? Maybe they have an idea, maybe not. So I think that's very special about electromagnetic fields, that people say, I know that I'm sensitive to it. In a way it's special, but in another way it's also not special. One of my first studies that I did was also to ask in a representative survey whether people feel sensitive to different factors like weather. And then from the Swiss population, about 30% said, yeah, I'm sensitive to the weather, or I was sensitive. Obviously to distress, a lot of people feel sensitive, so maybe you cannot sleep anymore if you are distressed. To air pollution, the same for noise, and to electromagnetic fields, it was rather low, so maybe 5% if you take those together who had that problem before, or say that they have it now. I think what is special about the notion that you feel sensitive is really that you have an exposure and that you can immediately observe that you react to it. So that is, if it's noisy, you cannot sleep, then you know, some people know I cannot sleep if it's noisy, so they would say I'm sensitive. Other people may say, it's not disturbing to me. So that's a different issue here. So it's really, usually this observation is based on short-term experiments on their own. And you see these 5% in Switzerland are quite in the middle of other papers that have published the prevalences between 1 and 10%. In Taiwan, they have hypothesized that it was very high in 2007 because of media report, and then it decreased. Obviously, this cannot be proved, but it seems plausible that the public discussion, as also Mile has just said, may have an impact on how well known this phenomenon is. We know all this definition. I don't have to talk about that, but I think just to make one point very clear, I think self-attribution for, let's say, long-term health risk is very rare. I've never heard somebody saying, I don't smoke anymore because I know I'm sensitive to tobacco and I will get lung cancer, or I'm sensitive to ionizing radiation. I mean, this is something, you cannot make this empirical evidence that you react maybe 30 years later. I mean, this is just not possible. And even if you just get a disease, like maybe you cannot sleep anymore, and you start to think what could be the reason, and Mile said that maybe a coping strategy that you find in a reason, and this could be electromagnetic field. But if this only occurs once, you cannot prove that, so it's maybe then just a hypothesis that you have. Whereas somebody who is repeatedly exposed to electromagnetic fields and then feels that he reacts or she reacts, obviously is then convinced that it is really must be a link. It's also interesting when we asked people, and this was in an epidemiological studies on symptoms and exposure to different electromagnetic fields, and it was general population samples. So most of them were asked twice in 2008 and 2009, and most of them said that basically they are not sensitive. But there are people like they said, I'm not sensitive in 2008, but then a year later they said, I'm electromagnetic hypersensitive, or we had used two questions, or they said, I assume or suspect that electrosmoke, which is kind of German word, is causing health problem to me. So you see the prevalence is quite high, so that's quite common, but it's not like a very fixed attribution, so that those who are very clear in their mind that they are sensitive, this is much smaller minority than this few percent we usually see in the studies. So the first study, when I started to do electromagnetic field research, of course, was then to really ask these people, what do you think? And apparently in Switzerland, this phenomenon was more common than in France already 20 years ago. So this study has started in 2001, and I found basically almost 400 people who said that they are electrosensitive, and they answered. And you can see the whole range of symptoms, different sources. At that time, there was a lot of discussion about mobile phone base station, and this was claimed to be the reason, but also mobile phone, cordless phones, and so on. What was interesting is that we could not identify any symptom pattern related to any type of exposure. So we did a lot of principal component analysis, cluster analysis, this kind of stuff. But basically it was just more or less random. So one hypothesis would have been that maybe if there's a causal association between sleep problems and base station, you would somehow see that this is more often connected, but this was not the case. And the other interesting thing, as I told before, a lot of people came to the conclusions that they are electro-hypersensitive based on own experience. So they said, I react within a few minutes when they are exposed. And obviously the gold standard for that is provocation studies, and several studies have been done on that, and I've been involved in one of that study in 2006 with Peter Ackermann and Niels Kuster, who was also involved. So the typical double-blind provocation setup, you have the same person is several times exposed to different conditions, and in this case they did cognitive tests during the exposure and asked questions about symptoms before and after each exposure. And when you look at the results, then just as an example, but this is basically seen in most of the provocation studies, we had two groups, the sensitive group and non-sensitive group, which were age and gender matched. And you could see that the sensitive group perceived more higher levels of field, but this is basically not correlated to the true field. And also the same for symptoms. The sensitive group perceived more or had more symptoms, but again, it was not correlated to the real exposure. What was interesting, and this is also seen in other studies as well, if we plotted the perceived exposure, not the real exposure, against the reported symptoms, we could see a clear correlation, like if people felt that they were exposed, regardless whether they were exposed, they reported more symptoms on average. And this obviously is what kind of indication for nocebo effect. That's just based on the expectation you report something. So let's, I mean, these studies are well known, and I think you would all agree on that, and probably many have seen the presentations by Gunhild of this paper from Schmidtchen, where these studies were nicely summarized. Basically, these studies show that EHS individuals, despite a part of it claims to do so, they cannot perceive exposure in the lab. There was one paper here from NAM where they also did these perception studies, and so there was a real exposure, and you see basically the perception accuracy of non-sensitive individuals was almost zero, and when electromagnetic sensitive individuals were exposed, they had almost a 50% perception rate. So you say, okay, not too bad, they can perceive it. But when you look what happens during sham exposure, then the non-sensitives were almost 100% sure that they were really not exposed. And the people here, they were basically also felt quite often that they are exposed, even there was nothing. So this means it's very important that when you do such kind of studies, that you have a proper balanced randomized setting. Otherwise, just by the preference of electromagnetic hypersensitive symptoms to claim more often to be exposed, you can create a bias if the design is not correct. So EHS individuals show more false alarms, so we have to be aware of that, and there was no associations between exposure and symptoms. And I know Darius already told me these studies is not the solution. I would say these studies are very good for these specific questions where the people react immediately what a part of the population is saying. But it may not be the end of the story. Maybe these studies don't find anything because the populations are too heterogeneous. Maybe there are a few hypersensitive individuals in this study collective, but they just are diluted in their overall statistics. So the solution to that would be that we do individualized provocation studies and that we have a better screening who to include in that study, so that we have a kind of diagnosis. The other questions that always comes up with these studies is, okay, this is not about short-term effect, it's about long-term effects. So let's talk about that. Obviously, you cannot do long-term experiments. You cannot do apply exposure for a year or two, so then you have to go into observational epi-study. And then we also, what does this mean for the treatment and for medical counseling? So these few aspects I just want to discuss in the following. So this individualized study, one has been done, published in Environmental International. You probably all have seen also the poster from Maries, where she has presented a study. In this Dutch study that has already been published, they really have individualized the exposure to the to each individual what they wanted. So the procedure was they only included people who said, I'm sure that I react within short time. Then they went home to these people with an exposure setup, very complex, where you could generate each signal, even radio frequency, low frequency, and they did some kind of pre-testing questionnaire about how certain they were about electromagnetic hypersensitivity, whether they could perceive the fields and all that kind of stuff, and then did an open provocation. So the study assistant with the people said, okay, let's put a little bit more power on the system, do you feel? And when the people were sure, they felt it. When they were sure, okay, let's say a 15-minute washout period is fine for me, I can do the experiment again. When they really agreed on an individualized protocol, then they started the test. They had to do it 10 times. And the idea was if somebody could detect the field or react to the field more than 8 times, this is what by chance you cannot reach that for a higher likelihood than 5%. So basically, of course, we could discuss about significant, but the likelihood that you do that by chance, 8 and more hits is quite small. Of course, if you have 40 people, you may have 2. And actually, they had 2. But not more. So basically, there was no indication that this could be perceived. And interestingly, if they ask people, I mean, one motivation for that study was also to see what happens to the people. Does it help somehow if they see they cannot perceive, but to find a different way to cope with their diseases? But interestingly, the self-rated EHS level has not much changed after they have been communicated the result. Also, the certainty being electromagnetic hypersensitivity has not been reacted much. They were less certain that they really react to electromagnetic field, but they still were sure that they were sensitive to it. So somehow it did not fulfill the expectations of the researchers so far. But still, I think this is a very interesting approach and should be done more than once. I think that can be helpful, and maybe one can change framings and things like that, so we could see whether this is really also helpful in terms of therapy. So the other question is to have better diagnosis, so that we really include in these studies people who have a real hypersensitivity, and obviously a possibility to do that would be to use biomarkers. And for some diseases, there are well-known biomarkers. If you had a heart attack, you can measure that you had a heart attack, so you have the creatinine kinase isoform and things like that. That tells you, okay, you had a heart attack. But for non-specific symptoms, by definition, there's nothing you can measure, because then if you could measure some biomarkers, then it would be non-specific. I mean, then it would be a specific symptoms. As the definition from of a non-specific symptom is that it cannot be explained by some of these biomarkers. So that's very difficult. And just as an example, I mean, obviously research goes into biomarkers. And for instance, depression, when you have to diagnose a depression, this is mostly done with an anamnesis of the doctor. He asks questions, and then he can check certain things, whether this fulfills the criteria of a diagnosis. But also there, they would like to have a biomarker, and sometimes you read this headline, oh, we have a biomarker found for diabetes. But then if you look closer, you see these biomarkers, and here is just one biomarker that have been proposed according to the depression score. You see the correlation is very weak. So for any complex disease, it's quite difficult to have just a biomarker that differentiates between diseased and non-diseased. I think it's pretty unrealistic, and this would certainly also be for something which is so heterogeneous like electromagnetic hypersensitivity. And the other question is, I mean, it's not only, I come back to that. So what we found in a review, and there were others review on that topic as well, whether EHS individuals are different than other people, let's say people who don't react. And if you look at all these studies, it was not a clear cut, but there was a tendency, basically, that EHS individuals had a tendency of higher sympathetic activity. Maybe the cortisol levels were slightly higher, or other indicators pointing a bit into the stress direction. But what does this mean? I mean, this is not even if there would be such a difference between EHS and non-EHS, there would certainly be a large overlap. And it would also not tell anything about the cause, because maybe people have higher stress because they felt stress from the EMF they feel everywhere, that they felt exposed. So you don't know whether this is the cause of these differences found in the biomarkers. So I think that is the very, very special thing about that if we talk about the expectation of electromagnetic sensitive individuals for biomarkers, they want to have a biomarker for the disease and the exposure, so that it's really linked together, which is very, very rare. So you're wondering whether this is possible at all. And to make it short, in principle, cannot be fully excluded. For instance, there are some papers showing that for certain carcinogenic substances, you have specific mutation markers. So then you know if you have that mutation, this is from that exposure. But this is very rare. And for instance, for ionizing radiation, this is very unspecific. I don't want to go in that detail. But in principle, it would be possible. But I think it's rather unlikely that this will happen for electromagnetic hypersensitivity if you don't even have a marker for the outcome per se. So we have to think about long-term effects. And I think if we go into long-term effects, and the question that you raised at the beginning, Darius, whether if there are effects, then obviously some people must be more vulnerable than the others, because otherwise everybody would be concerned. And what is the difficulty with the long-term studies? This is also from our study. What we see is not unexpected, I would say. Electromagnetic hypersensitive individuals, they have more symptoms. And they are less exposed, so they use less cordless phone, they use less often Wi-Fi, which is not a surprise. Obviously, if you think this is a cause of disease, you try to avoid them. What this means for observational research is basically you can almost not investigate it, because you would even see negative correlation. The higher the symptoms, the lower the exposure, so it would look like fields are protective. And this is really a challenge. So it's not so simple to do health research in electromagnetic hypersensitive individuals. So if it's about health research, then I claim you have to look into the general population, because otherwise you have too much risk of bias. So we have done that in a study, and basically we haven't seen such associations. And just to look at it, we also looked in a separate analysis, which was just a side analysis, what happens in the 130 individuals that I showed at the beginning who claimed to be electromagnetic hypersensitive. And what we saw is basically those who were exposed above the median, so the exposure was modeled, they hadn't more symptoms. And also sleep disturbance in relation to modeled exposure from base stations and other transmitter was not different between exposed and unexposed. We also did a change analysis, so because there was a one-year follow-up, so we looked at those who have decreased exposure and those who have increased exposure, and whether their symptom has changed compared to those who had more or less the same exposure at the 2 time points. And here, this was like, just in the question asked before, some had a decrease in exposure and a decrease in symptoms. So this could be, of course, refer to an effect. Could be also chance, of course, because it's not a consistent pattern across. But it could also be reverse causality or a nocebo phenomenon, so that people who were aware that they have reduced exposure felt better, and then they had less symptoms. And you see, it's so difficult to interpret, so that makes this research in this specific group very difficult. We also worked with environmental doctors in Switzerland who have offered a counseling for electromagnetic hypersensitive people. And this was done for 2.5 years. And about 255 people have contacted there. And at the end, 21 could be included in a study to see what really happened with them. So it's already interesting also to see this number, 255, and thereof about 185 had really a health problem. So if you compare that with 5% of the population, which would be in Switzerland at that time maybe 6 million, 5%, Yeah, you can count. I cannot calculate on if I'm giving a talk, but it's quite a high number, and obviously it's much less that have a high pressure than to really go and consult. And when we looked what happened to these people after a year, so they got a lot of consultations, sometimes measurements were done, and we looked at the health effect before the counseling and after the counseling, not much has changed. It really shows how difficult it is to help electromagnetic hypersensitive individuals. It was clear that the trust between doctor and the patients played a big role, because for some people the situation has improved, for others it got worse, and trust into the doctor was one of the important factors. Also, if people could reduce exposure, it was not significant, but there was a tendency that these people felt better. But again, is it nocebo, or in this case placebo? That's the most likely explanations. And what was interesting, and all the doctors participating in that experiment said they really wanted that the doctor proves that there's an individual cause, that electromagnetic fields is the cause of their disease, which in a way is very special, because if you go to a doctor with a heart attack or something, or in a hospital, usually it would not be your first questions why you get that heart attack. I mean, then usually if you get a cancer, I mean, maybe you start to think about it, but most important would be that you treat your disease. And that is also something which has been realized in this project. It's very important to maybe give less weight on the causality question, but really on the treatment of the problem, on the medical help. So to summarize, basically, there's two pathways that are on stake and that we have to discuss. One is the subjective pathway, which is well established. We know some people, they feel exposed and they experience symptoms out of that and they don't feel well. Then the other question, is there a biological effect? And if such an effect is, then it depends who is vulnerable. And that's clear that not everybody will react to it. But this is not established so far. And just to give an idea about vulnerability, there was a recent paper that claimed, that looked at brain cancer incidence in Korea. And what you see here in the dashed line is the observed brain cancer incidence. And then they have compared what would happen if the risk to get brain cancer would be 20% increased for mobile phone users, so relative risk 1.2. Then it would increase like that. It would increase like that with a 1.5, and with a risk of 2, it would increase like that. Obviously, this did not happen. So when you count now who would be susceptible, this would mean that the incidence, instead of 3 cases per 100,000 person years, it would be 3.6. So this means that you would expect that 6 persons per 1 million person years are vulnerable and are reacting to electromagnetic fields. So if we talk about cancer risk in a realistic range that has not been fully disproven at the moment, so let's say 10–20%, the number of people who would be susceptible is very low. So it's not so easy that you just can do an experiment and just take biomarkers and then you would find such people, because you have to screen millions of people to really see them. Just that we are aware of that, I think it's very important. So it needs large studies or very sensitive biomarkers. So to summarize, obviously science can never prove that something does not exist. But what we can prove and what we know, if there are electromagnetic hypersensitive individuals, it would be a very small minority. Maybe there's nobody, but it's certainly not everybody who is claiming, because otherwise we could have demonstrated. And I think it's very important also for future discussion that if we talk about self-reported electromagnetic hypersensitivity, we should not confuse that with biological vulnerability and susceptibility. These are two different concepts. And if there are any health effects from electromagnetic fields, there are vulnerable people. But there's no way that people can know about long-term vulnerability. And this we shouldn't expect. So we should really keep that separate. Otherwise, we will be stuck in not productive discussion. So EHS by definition can only refer to somehow acute effect, and for that, randomized double-blind studies are really the how you call it, the gold standard, and they should be done. Obviously, biomarkers would be useful for research, so because then you could maybe see effects which are more subtle in smaller collective than if you go for disease. And it could also be very interesting if you could find biomarkers which are which represent exposure. So we know, oh, those people who have high score on that biomarker, they have been exposed in the past. That would be very useful. So we could do much better exposure assessment than we do nowadays. So, yeah, I think if there are long-term effects, I made that statement already, there will be vulnerable populations, but it would be very difficult to find them, and it would be a very small number for diseases which have already been investigated and not found to be correlated with exposure. Okay, I think we take questions after your talk. If this